Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! Hi, aspiring gynoncs. This is the third episode in our series on ovarian cancer. Today, we're reviewing recurrent platinum-sensitive epithelial ovarian cancer. Maya, what are our learning objectives?
Our objectives are to discuss definitions of recurrent ovarian cancer and the ways to detect recurrence, to discuss preferred systemic therapy regimens for platinum-sensitive recurrent epithelial ovarian cancer, to explore the use of bevacizumab in platinum-sensitive recurrent EOC, to discuss the use of PARP inhibitor in platinum-sensitive recurrent EOC, as well as recent updated FDA regulations surrounding PARP-I in this setting, and to describe current published research supporting the use of other targeted agents, including immunotherapy, in the treatment of platinum-sensitive recurrent EOC.
Let's get started. Recurrent ovarian cancer is defined by the platinum-free interval, which is the amount of time from completion of platinum therapy to the detection of recurrence. Ovarian cancer is considered platinum-sensitive if this interval is greater than 6 months. The platinum-free interval correlates positively with progression-free survival, overall survival, and response to subsequent treatment, including both platinum and non-platinum regimens. Patients that have longer platinum-free intervals, for example, recurrence of disease greater than 1 year versus 6 months after their last platinum treatment, tend to do better overall. Platinum-resistant disease is defined as time from completion of platinum therapy to first recurrence being less than 6 months, and platinum-refractory disease is progression of disease while on first-line platinum treatment. Our next episode will discuss management of platinum-resistant disease. It seems to me that defining what counts as recurrence is really important to decide which of these categories a patient falls into. Maya, how do we do that?
Great question. Providers use a combination of symptoms, imaging, and CA-125 to inform care of their patients. Often, the CA-125 rises months before recurrent disease can be seen on CT imaging. So, what should we use? In 2010, the MRC OV05 EORTC 55955 study sought to answer this question. It was a randomized controlled trial which evaluated the potential benefit of treating people based on rising CA-125 alone versus imaging. Patients underwent a physical exam and CA-125 test every 3 months. If the CA-125 reached greater than 2 times the upper limit of normal, patients were then randomized to immediate treatment versus delayed treatment at the time when disease was visualized on imaging. If the patient was randomized to delayed treatment, they would continue with every 3-month evaluation until evidence of clinical relapse. Ultimately, the study found that overall survival was not different between the 2 arms. Said another way, there was no survival benefit with treating early based on rising CA-125, and the value of routine CA-125 surveillance after complete response from first-line chemotherapy was not validated in this study. The general consensus is to define recurrence based on imaging. So let's say we're doing Q3-month evaluations, and now there is evidence of clinical relapse. What are some options for treatment?
In some cases, secondary cytoreduction could be an option. We'll discuss this in much more detail in our surgical considerations for ovarian cancer episode. But per the NCCN, if a patient develops a recurrence more than 6 months following initial chemotherapy, has a good performance status, does not have ascites, and has a single focus or limited foci of disease that are amenable to resection, secondary cytoreduction can be considered. One may want to consider a diagnostic laparoscopy and validated scoring methods at time of surgery before proceeding. What about chemotherapy?
Chemo is generally the go-to treatment for platinum-sensitive recurrences, and choice of option is a big and confusing topic. For patients with platinum-sensitive recurrence, platinum-based combination chemotherapy is recommended for a total of 6 cycles. For patients who can't tolerate combination therapy, the recommended single agent is carboplatin or cisplatin, although a doublet is strongly preferred. The combinations of carbotaxol plus minus bev, carbodoxil plus minus bev, and carbogem plus minus bev, and cisplatin and gem are all Category 2A recommendations. Sydney, do you want to walk us through how we got to those recommendations?
Sure. The Gordon trial, published in 2001, evaluated single-agent Doxil versus single-agent topotecan at the time of recurrence for platinum-sensitive or resistant or progression for platinum refractory. Patients were stratified by platinum sensitivity and bulky disease. In the platinum-sensitive group who received Doxil, PFS was improved by 5 weeks and OS improved by 37 weeks. In the platinum-resistant group, there was no difference. Stratifying by bulky disease, there were also no differences in outcomes between the two arms. ICON-4 was published in 2003. This phase 3 RCT evaluated the addition of paclitaxel to conventional platinum chemotherapy in patients with platinum-sensitive recurrent EOC. In the combination arm with Taxol, PFS improved by 3 months and OS improved by 5 months. There was no significant difference in quality of life or completion of regimen. This established that combination therapy of Taxol plus platinum-based chemotherapy is more effective than single-agent treatment at the time of recurrence for patients with platinum-sensitive disease. Pfisterer et al. Published a trial in 2006 that built off of the results of both ICON-4 and the Gordon trial. The authors recognized that Taxol can have significant dose-limiting neuropathy in some patients. They aim to evaluate whether carbogem is a reasonable alternative. They compared carbo alone versus carbogem at the time of first recurrence. PFS was improved by 3 months in the doublet arm. There was no difference in OS, but the study was not appropriately powered to show this difference. There was no difference in quality of life. However, there was an increase in grade 3 or 4 toxicity, primarily hematologic, in the combination group. Calypso, published in 2010 with long-term follow-up data published in 2012, also sought to investigate alternative options to carbotaxol, which may be less neurotoxic. This was a phase 3 non-inferiority study evaluating carbodoxil versus carbotaxol. Nearly 1,000 patients were enrolled, and they were included if they had greater than 6 months no evidence of disease and had prior treatment with at least one taxane. The study included patients who had received only 1 to 2 prior lines of chemo. At a median follow-up of 22 months, PFS was 11.3 months in the carbodoxil group and 9.4 months in the carbotaxol group. At the long-term follow-up of 49 months, overall survival was not different. In regard to toxicity, 28.4% of patients in the carbodoxil and 36.8% of patients in the carbotaxol group experienced severe non-hematologic side effects. This likely explains the lower rate of discontinuation in the carbodoxil group versus the carbotaxol group, 6 and 15% respectively. There was a large crossover into the Doxil arm among patients originally stratified to Taxol. This study showed us that carbodoxil is non-inferior to carbotaxol, is better tolerated with less treatment discontinuation, and may have less long-term side effects from neuropathy. It also had significantly less carboplatin hypersensitivity reactions, which can prove to be a challenging clinical situation if carboplatin desensitization is needed. There was a thought that carboplatin plus Doxil may have improved PFS compared to carbotaxol, but importantly, overall survival was not shown to be different between the two combination therapies.
Interesting. While we do know that recurrent ovarian cancer is not curable, it certainly is treatable. Among platinum-sensitive patients at the time of first recurrence, response rate is around 60%. Gershenson et al. In 1989 showed that the best response to reusing platinum is seen in patients with a greater than 24-month platinum-free interval. Are there any other agents we should be aware of?
Yes. There is a Category 2A recommendation for carboplatin plus albumin-bound paclitaxel for patients with taxane hypersensitivity. There are recommendations for modifications in patients greater than 70 years and those with comorbidities in the guidelines. In addition, single-agent chemos can be used if patients cannot tolerate a doublet therapy. The response rates are generally 25 to 40%. Okay, so we've talked about our cytotoxic agents used in the setting of platinum-sensitive recurrence. What's the role of bevacizumab?
Great question. The Oceans trial was published in 2012 with long-term follow-up published in 2015. This was a phase 3 RCT comparing carboplatin and gemcitabine with or without bevacizumab. Nearly 500 patients with platinum-sensitive first recurrence measurable disease without prior bevacizumab treatment were enrolled. The primary endpoint of PFS was favorable towards the bevacizumab arm, with a PFS of 12.4 versus 8.4 months. Overall survival was not different between the two arms. The rates of neutropenia and febrile neutropenia were similar between the two arms. However, 17% of patients in the bevacizumab arm experienced grade 3 to 4 hypertension versus less than 1% in the carbo-gem arm. Similarly, proteinuria was 8.5% versus less than 1%. There were also 2 GI perforations out of the 240 patients in the bevacizumab arm after treatment discontinuation. This study showed that the addition of Bev to carbo and gem, followed by Bev maintenance, can improve progression-free survival, but doesn't affect overall survival. It also carries several unique toxicities. Because of this trial, carbo, gem, and Bev is an option for treatment. GOG 213 was a bifactorial phase 3 trial published in 2017. It had 2 objectives. The first was to evaluate secondary cytoreduction in platinum-sensitive disease, and the second was to evaluate the addition of bevacizumab to chemotherapy in platinum-sensitive disease. We'll discuss the surgical objective further in a subsequent episode. 674 patients were enrolled in the chemotherapy phase, with 75% of participants having a PFI of greater than 12 months. For the chemotherapy objective, patients were randomized to investigator choice chemo, which was either carbotaxol or carbo-gem, and then were given Bev and Bev maintenance or not until disease progression or toxicity. Progression-free survival was 13.8 versus 10.4 months, favoring the bevacizumab arm, which was a statistically significant improvement. These results were consistent regardless of participation in the surgical cytoreduction objective, regardless of the platinum-free interval or prior treatment with bevacizumab. Overall survival was not statistically significant in the intention to treat population. However, upon subsequent analysis, investigators found that 45 patients were incorrectly stratified based on their platinum-free interval. And then when they were correctly stratified in a modified analysis, overall survival did show a statistically significant difference with a hazard ratio of 0.8. This correlated with a 5-month overall survival benefit. However, these results must be taken with caution because of the modified stratification that doesn't ensure balanced baseline characteristics between the two groups.
Okay, so we have a couple of studies showing improved PFS and one with modified analysis showing improved OS for combination chemo with Bev. But remember our prior comment that we made. What about Bev alone?
GOG 170D evaluated the use of single-agent bevacizumab in patients with both platinum-sensitive and platinum-resistant disease. The investigators found an overall response rate of 21% and a 39% progression-free survival at 6 months. Age, number of prior regimens, and platinum sensitivity were not associated with a response. Bevacizumab alone carries a Category 2A recommendation for those with both platinum-sensitive and platinum-resistant disease.
I heard you mention that the Oceans trial excluded patients with prior bevacizumab treatment, but GOG 213 included patients regardless of prior bevacizumab therapy. Has anyone looked at differential outcomes between the groups, those who have received Bev during primary treatment versus those who did not?
Yes. So, to reiterate, the results of GOG 213 showed similar benefit observed from the addition of bevacizumab in patients who had received prior bevacizumab therapy versus those who had not. Notably, this subgroup of patients who had received prior bevacizumab therapy was only about 10% of the total intention to treat population. The MITO 16B MANGO OV2 NGOT OV17 trial was published in 2021. This was a phase 3 RCT of patients with recurrent platinum-sensitive epithelial ovarian cancer who had received bevacizumab during their first-line treatment. Patients were randomized to standard platinum doublet therapy with carbotaxol, carbogem, or carbodoxil versus a platinum doublet with bev. The study found that PFS improved by 3 months with the addition of bevacizumab with no new unexpected toxicities. Taking all of these studies into account, in the recurrent setting, bevacizumab tends to grant about a 4-month benefit in progression-free survival, but overall survival is not consistently improved. With bevacizumab, there are additional toxicities to consider, and no study has demonstrated cost effectiveness.
Got it. Let's switch gears and talk about PARP inhibitors. At the time of the airing of this podcast, 3 PARP inhibitors, olaparib, rucaparib, and niraparib, are FDA approved for use in platinum-sensitive ovarian cancer. They each have different and specific indications for use informed by a number of studies. Let's go over the trials that informed both NCCN and FDA recommendations and approvals. Study 19 was a phase 2 trial published in 2012, which evaluated maintenance olaparib in platinum-sensitive EOC. In this study, BRCA status was not required to be known. In the intention to treat population, 22% were BRCA mutated, 15% were BRCA wild type, and 63% were status unknown. Overall, the PFS benefit was 8.4 versus 4.8 months. Solo 2/NGOT OV21, published in 2021, evaluated olaparib maintenance after chemotherapy in patients with platinum-sensitive high-grade serous ovarian cancer or high-grade endometrioid ovarian cancer with BRCA mutations who had received 2 or more prior lines of chemotherapy. Progression-free survival improved from 5.5 months to 19.1 months with olaparib maintenance, but overall survival was not statistically significant. Solo 3, published in 2020, with follow-up overall survival data published as an abstract in Gynecologic Oncology in 2022, investigated olaparib monotherapy versus non-platinum chemotherapy in patients with heavily pretreated, meaning greater than or equal to 2 prior lines of platinum chemotherapy, platinum-sensitive, BRCA1/2 mutated epithelial ovarian cancer. In patients with measurable disease, the overall response rate was 72.2% versus 51.4% with olaparib versus chemotherapy. In the subgroup who had received 2 prior lines of treatment, the overall response rate favored olaparib with 84.6% versus 61.5% chemo alone. Progression-free survival was also statistically significantly improved with olaparib versus chemotherapy, with the PFS being 13.4 versus 9.2 months, respectively. In the follow-up analysis, overall survival was not different between the 2 groups. As a result of these studies, the FDA indication was withdrawn for PARP monotherapy for patients with 3 or more prior lines of chemotherapy, even if they were BRCA mutated. Maya, what's known about rucaparib?
Rucaparib was evaluated in the Ariel study series. Ariel 2, published in 2017, was a phase 2 study which aimed to evaluate the utility of loss of heterozygosity to predict response to rucaparib in recurrent platinum-sensitive high-grade serous and endometrioid ovarian cancer with at least 1 prior platinum chemotherapy. The patients were classified into predefined homologous recombination deficiency subgroups: somatic or germline BRCA mutation, genome-wide loss of heterozygosity in the tumor or LOH high, and LOH low. Treatment was with rucaparib until disease progression or toxicity. The study found that progression-free survival was best in the BRCA mutated group with a PFS of 12.8 months, followed by the loss of heterozygosity group and LOH low group. with 5.7 and 5.2 months respectively. Ariel 3, a phase 3 double-blinded RCT, also published in 2017, had a similar question, assessing rucaparib maintenance in patients with 1, genetic or somatic BRCA mutation, 2, BRCA wild-type HRD positive, i.e. LOH high, and 3, BRCA wild-type and LOH low or indeterminate. Progression-free survival was improved in the BRCA mutated and HRD positive LOH high populations compared to LOH low, with 16.6 versus 13.6 versus 5.4 months respectively. In the intention to treat population, PFS was 10.8 months versus 5.4 months with placebo. This study found that across all primary analysis groups, PFS was significantly improved, giving further evidence for PARP inhibitor maintenance. Overall survival results were presented at ESGO in 2022, with no overall survival benefit in the intention to treat or any subgroup. Finally, Ariel 4, a phase 3 RCT published in 2022, had some significant differences in inclusion criteria than its predecessors. This study included patients with recurrent BRCA mutated epithelial ovarian cancer with platinum-sensitive or platinum-resistant disease. Another important difference is that Ariel 4 evaluated rucaparib monotherapy and not maintenance versus standard of care chemotherapy. In the intention to treat population, there was an improvement in progression-free survival with rucaparib, with a median PFS of 7.4 months in the rucaparib group versus 5.7 months in the chemo group. An updated survival analysis was presented at ESMO 2023. In the overall intention to treat groups and the platinum-sensitive disease groups, the overall survival did not differ between rucaparib and standard of care. It's interesting to note that 78% of patients who progressed on chemotherapy crossed over to PARP inhibitor, meaning that 90% of people in this trial eventually got a PARP inhibitor. When excluding these crossover patients, there was a survival benefit observed of 19.4 versus 8.1 months. Patients with platinum-resistant disease treated with PARP monotherapy had an overall survival detriment with a median overall survival of 14.2 versus 22.2 months with a hazard ratio of 1.5. Sydney, do you want to take on our last PARP inhibitor, niraparib?
Of course. NOVA, published in 2016, evaluated niraparib maintenance in recurrent platinum-sensitive ovarian cancer with greater than or equal to 2 prior chemotherapies stratified by the presence or absence of a germline BRCA mutation. In the patients without a germline BRCA mutation, they were defined by my choice HRD test as either A, HRD positive with a somatic BRCA mutation, B, HRD positive BRCA wild type, meaning other mutations in the HRD pathway were mutated, or C, HRD negative. The patients with germline BRCA saw the most benefit in progression-free survival with 21 versus 5.5 months. The non-germline BRCA but HRD positive groups had a PFS of 12.9 versus 3.8 months. And the overall non-germline BRCA cohort, including those with and without HRD mutations, had a PFS advantage of 9.3 versus 3.9 months. Notably, overall survival data was not significant for any subpopulation, even the germline BRCA mutation. Subsequently, FDA approval has been withdrawn for all maintenance therapy for patients without germline or somatic BRCA mutations for recurrent platinum-sensitive disease. These studies didn't define HRD in the same way, and they didn't use the same groups for comparisons, so it's important for thinking about which group will benefit the most. A good rule of thumb is that people with germline BRCA mutations always seem to derive the most benefit from using PARP inhibitors. The next best are somatic BRCA mutations, followed by HRD positive without BRCA mutations. The patients who have platinum-sensitive disease but are HR proficient get a little benefit, but not much. So with all of that, which is a lot of info, let's distill it down even more. Maya, what is the status of PARP inhibitor FDA approvals as of 2023?
There's no indication for PARP monotherapy at this time in recurrent disease, either platinum sensitive or platinum resistant. PARP inhibitors can be used for second or greater line maintenance therapy following response to platinum-based chemotherapy for patients with recurrent platinum-sensitive ovarian cancer in the following situations. For olaparib and rucaparib, any patient with germline or somatic BRCA deleterious mutation. For niraparib, germline or suspected germline BRCA deleterious mutation. Said another way, FDA approval has been removed for BRCA wild-type patients given lack of overall survival benefit. As we'll discuss in the following episode, for platinum-resistant patients, PARP inhibitor are generally not recommended.
The last thing to mention in regard to PARP inhibition is the concept of PARP after PARP. It's generally not recommended given that there isn't much data to support it at the time of airing of this episode. Oreo/NGOT OV38 was published this past year in 2023. It studied patients with or without BRCA mutations with heavily pretreated, meaning greater than or equal to 3 prior lines of chemo, platinum-sensitive disease who had previously received 1 PARP treatment. Patients were re-challenged with olaparib and were found to have response to platinum when the treatment was started. In the BRCA mutated cohort, progression-free survival was 4.3 months versus 2.8 months favoring olaparib. In fact, 1-year PFS was 19% in that group versus 0% without olaparib. In the BRCA non-mutated group, PFS was 5.3 months with olaparib rechallenge versus 2.8 months with placebo. Time will tell how we use this data to inform treatment decisions. Maya, do we have any other agents that can be of use in platinum-sensitive ovarian cancer?
We do, but only in specific circumstances. That's why tumor sequencing for genetic alterations is recommended for ovarian cancer, both in the upfront and in the recurrent setting. Especially if patients have not had tumor sequencing in the upfront setting, it should be performed in the recurrent setting, as results can be very helpful to identify beneficial targeted therapies. The Keynote 100 trial was published in 2019 and studied single-agent pembrolizumab in patients with recurrent EOC until progression of disease, intolerable toxicity, or maximum duration of treatment of 2 years. There were 2 study groups. Cohort A were patients who had received 1 to 3 prior lines of treatment and had a platinum-free interval between 3 to 12 months. And Cohort B were heavily pretreated patients with 4 to 6 prior lines of treatment and with progression-free interval of greater than 3 months. Patients were stratified by the combined positive score, which was defined as the number of PD-L1 staining cells, including tumor cells, lymphocytes, and macrophages, divided by the total number of viable tumor cells times 100. In the final analysis presented in 2020, overall response rate in Cohort B increased to 18% from 9.9% if the PD-L1 CPS was greater than 10%. Median overall survival was 18.7 months and 17.6 months in Cohort A and B, respectively. The overall survival increased to 21.9 months and 24 months in Cohorts A and B if the CPS score was greater than 10%. 75% of patients had treatment-related adverse events, with 20% being grade 3 to 4. There were 2 treatment-related deaths related to Stevens-Johnson syndrome and hypoaldosteronism.
Entrectinib and larotrectinib can be considered for Ntrec gene fusion positive tumors. There is very limited data surrounding the use of these agents in ovarian cancer, and this mutation likely occurs in less than 1% of ovarian cancers. However, if patients have these mutations identified on sequencing of their tumors, these agents can be considered. Sabaya et al. Published a phase 1/2 trial of selpercatinib in patients with RET fusion-positive solid tumors in 2022. There was 1 patient with ovarian cancer who had a partial response with a response duration of 14.5 months at time of reporting. Thus, this agent can be considered for these particular patients.
Pazopanib is another agent with some activity in recurrent platinum-sensitive ovarian cancer. In a phase 2 trial of 36 patients, overall response rate was 18% in patients with a complete response to initial therapy. 75% of the total patients were platinum sensitive, although responses were not stratified by platinum sensitivity status. Inclusion was limited to patients with low volume disease. Mirvetuximab plus minus bevacizumab can be considered per the NCCN recommendations. However, it's important to note that the trials conducted to evaluate the drug activity were performed in patients with platinum-resistant ovarian cancer. Thus, that is the FDA indication for the drug. Finally, in some situations, treatment with hormonal therapy can be reasonable.
What an informative episode. I really learned a lot today. Here are your key takeaways. Recurrent ovarian cancer is described based on the platinum-free interval, with platinum-sensitive disease recurring greater than or equal to 6 months after completion of the most recent platinum therapy. Recurrence can be detected based on CA-125 or examined imaging findings. An RCT which compared treatment of recurrence based on CA-125 rise alone versus after imaging confirmed recurrence did not show a difference in overall survival between the two strategies.
For platinum-sensitive recurrences, a platinum-based combination is preferred. There are many options, but carbotaxol and carbodoxol both have a Category 2A recommendation for use in this setting, based on ICON 4, which evaluated Taxol and a platinum therapy versus platinum alone, and Calypso, which evaluated carbodoxol versus carbotaxol. Response to therapy is linked to the PFI, with greater responses with longer PFI.
Bevacizumab can be used in combination with systemic therapy based on results of GOG 213 and the Oesch trial. Bev can also be considered for single-agent therapy in this setting based on GOG 170D. The MITO16B and GOG 213 trials also give supportive evidence for using bevacizumab again in patients who receive bevacizumab with upfront therapy. Remember that bevacizumab is contraindicated in patients with a risk of GI perforation.
PARP inhibitor use in the recurrent ovarian cancer setting has changed dramatically in the last few years. PARP inhibitors do have approval for use in certain patients with platinum-sensitive ovarian cancer. These approvals include olaparib, niraparib, or rucaparib maintenance in patients with germline or somatic BRCA mutations. PARP inhibitors are not approved or recommended as solo therapy for recurrent ovarian cancer, and generally are recommended for patients who have not had previous PARP inhibitor, i.e. only for PARP-naive patients. However, the OREO-NGOT-038 trial published in 2023 did demonstrate about a 1.5-month survival benefit in BRCA-mutated patients who were re-challenged with PARP inhibitor.
The use of other targeted therapies can be considered in platinum-sensitive ovarian cancer and can be guided by the results of tumor sequencing. The KEYNOTE-100 trial investigated pembrolizumab in patients with recurrent ovarian cancer and demonstrated a best overall response rate in patients with a PD-L1 CPS of 10% or greater. Pazopanib also elicited an overall response rate of 18% in patients with recurrent ovarian cancer and low-volume disease. Other targeted therapies can be considered based on specific mutations identified on next-generation sequencing.
This has been another episode of Ready, Set, GYO, your source for all things gynonc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson. We'd like to thank Dr. Ryan Spencer, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.